Assalamu alaikum. Today we will be discussing a clinical scenario. Now let's get started. The question is, a 40-year-old smoker has presented with complaints of respiratory distress on climbing stairs. The epidiameter of chest is more than transverse diameter of chest in the patient. Chest X-ray was performed, which is the best management of this patient. Now note an important point to understand that we all have shoulder to shoulder diameter, that is transverse diameter, more than what we have AP diameter. But in this case, AP diameter is more than transverse diameter. That means this patient has barrel shaped chest, and barrel shaped chest, as you all know, occurs in COPD, and this patient is also a smoker. So we are now having almost a diagnosis of COPD. But by looking at the X-ray, students can be confused between pneumothorax and COPD. Let's discuss the X-ray findings which we see in pneumothorax. In pneumothorax, whether it is tension pneumothorax or spontaneous pneumothorax, you would see a deep sulcus sign on the affected side, means the costophrenic angle on one side will be inferiorly located compared with the opposite side, and it is much more pointed. Other distinguishing point is, in normal chest X-ray we are able to see blood vessels, or you may call it bronchovascular markings, but in case of pneumothorax you will not find these markings in most parts of the lung. The lung on the affected side will appear more black, more lucent than normal, because whole lung tissue is collapsed and atelectated and remained behind the air, which appears more black on the X-ray. But in chest X-ray of COPD patient, you can notice bronchovascular markings and flattening of CP angle, and heart is tubular in shape, all pointing towards the diagnosis of COPD. Based on this, let's look at the options given. A is insert wide bore needle in second intercostal space mid-clavicular line. You see, option A is given for tension pneumothorax, which is not matching with the diagnosis of this case. Option B is insert wide bore intercostal drainage tube in fifth intercostal space anterior axillary line. Now see, why do you put chest tube? You either put chest tube in case of empyema, or you would put chest tube in patient of pneumothorax. So both options A and B, both are the treatment of pneumothorax or empyema. Now look at option D. Please notice, high flow oxygen is not given to COPD patient, because high oxygen saturation can deteriorate patient, because high SpO2 would abolish respiratory drive, and SpO2 is kept in the range of 88% to 92%. And moreover, we give high flow oxygen to the patients of COVID-19 pneumonia. So the correct answer is option C, quit smoking, as quitting smoking is a factor that would be helpful in the primary management of this patient. So the answer is C, quitting smoking. I hope you all would like this video, and the discussion on this clinical scenario would be helpful for you all, and step by step you would be able to approach the right answer. Thank you.